Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Practical Perspectives and Management of the Patient with Mantle Cell Lymphoma and the integration of BTK inhibitors into the therapy of these patients. We have a great faculty today, Dr. Tycel Phillips from the City of Hope Comprehensive Cancer Center in Duarte, California, and Dr. Michael Wang from the MD Anderson Cancer Center in Houston. We're here to talk about one of the hottest topics in medical oncology, upfront treatment, and particularly the use of BTK inhibitors in the management of mantle cell lymphoma. Really curious what the faculty has to say. I met with Michael about a year ago to discuss this in a program, so this is a good chance to update. I met with him yesterday, actually, and we recorded a presentation that goes through all the data. Today, we're just going to chat mainly. We're going to show slides, but Michael recorded a presentation with me. It's in the chat room, and we'll also be distributing it when we distribute this, that goes through in detail some of the key trials that we're going to talk about today. And as always, we will be talking about the use of unapproved agents and regimens, so check out the package insert. Here's where we're heading. I just want to warm up a little bit and talk a little bit about CLL and mantle cell to start with, and then we'll jump into the main show, so to speak. I'll talk about first-line therapy. We'll look at some of the data, and then we're going to look at some cases. Then we'll look at relapse disease, see where pirtobrutinib fits in, where CAR-T fits in, and particularly the issue of the management of high-risk patients. But Tycel, we did a program last week, as we've done so many programs on CLL in the last couple of years. We did one with Matt Davids last week. Matt from Dana-Farber, we presented a bunch of cases, but we also talked about this press release. That's the way it is in oncology nowadays. You see a press release and you know something's about to happen. According to Matt, this is going to happen at ASH, which is a phase 3 first-line trial in CLL, the Amplify trial. And we see from this press release that it's a positive study. Matt and a lot of other people think it might be practice-changing, actually, in terms of first-line therapy of CLL, looking at acalabrutinib plus venetoclax, or acalabrutinib, venetoclax, and obinutuzumab. And Michael reminds me a lot of the trials we were going to talk about in mantle cell. And of course, we know there's a big overlap. Actually, one of the cases we presented to Matt was a patient who was initially diagnosed in the community with CLL. On further workup, was found to have mantle cell. So I don't know why I'm bringing all this up, other than, first of all, I get really excited when I see press releases that look like they have some pretty interesting information. I was just kind of curious if you have any general thoughts, and also this issue of CLL and mantle cell biology in clinical. I'll start out with you, Tycel. Any thoughts?
No, I think it's an exciting data set. I think it'll be important to see if there's any added benefit to the CD20 antibody, and since it's a fixed duration, how does the PFS compare to obinutuzumab, venetoclax, or alternatively what we know with the single agent BTK inhibitors?
So, Michael, one of the things I was curious, I know you see a lot of patients who are initially thought to have CLL and then found to have a mantle cell. Maybe you can just talk a little bit about the clinical presentation of mantle cell with a CLL type of variant, and also the impact of obinutuzumab versus rituximab in mantle cell versus CLL.
So a lot of people see that CLL is a cousin of MCL. So I happen to agree, because many agents are shared between the two diseases, and many therapy strategies are very similar. So you can do the exactly amplified trial in mantle cell lymphoma. That would be a good trial. So CLL is more prevalent than MCL. That's why in the community, and even among academic community, when you see a patient with a lymphocytosis, the first thing jumping into the mind is CLL. But MCL could also present like CLL with no lymphadenopathies, but bone marrow infiltration and splenomegaly, exactly like CLL and with the lymphocytosis. So the only difference is in the pathology analysis, MCL carries the 11-14 translocation or overexpressed cyclin D1 which will be separated from CLL. So a lot of the times people are referred to me as MCL. I found out they are CLL. A lot of times M. Anderson CLL referred to a mantle cell lymphoma to me because initially they were sent there for CLL. This is very important to know, to keep in mind that MCL could present exactly like a CLL. And in terms of this trial, I really think this trial is a very good, well-designed trial compared with FCR. FCR used to be a very effective therapy, and then we find out the BR is as effective but less toxic. But these are chemotherapies, right? Now we have two oral agents, acalabrutinib venetoclax oral therapy, which showed advantage, and then we plus a obinutuzumab CD20 antibody, and we also have good activity in this amplified trial. And I'm really looking forward to hear the presentation of this trial. And regarding CD20 is more densely expressed in MCL and not as dense at all in CLL. That's why you use the CD20 antibody such as the rituximab. You give it to the CLL, and you have good reduction of the cell. You don't have much tumor lysis. But for mantle cell lymphoma, you give a little bit of a CD20, it could be a dramatic reaction because the density, the cell lies very much, the cytokine storm could be released. So obinutuzumab is probably compared with rituximab in B-cell lymphomas outside of mantle cell lymphoma. Within the mantle cell lymphoma, I think personally they are equally sensitive. And maybe some of the patients could not tolerate the rituximab because it's a chimeric human and mouse antibody, and obinutuzumab is fully human. So sometimes we have serum sickness to Wang, and we can use obinutuzumab to reduce the risk.
So I want to kind of get into the data here in the first-line therapy, and this is a slide that Michael put in the beginning of his talk, kind of outlining the history of agents being approved for mantle cell. And you see, as time has gone on, we've had now, now we have 3 BTK inhibitors since ibrutinib is no longer being used. But with pirtobrutinib, we have 3, and we now have CAR T therapy. And of course, as Michael was just alluding to, there's a lot of interest in chemo-free upfront therapy. But Tycel, I wanted to get your take first on the SHINE trial. Looking at combining ibrutinib with BR, it turned out to be maybe a little bit more complicated than at least I thought it was going to be. I'm curious what your take was on the findings here, both in terms of efficacy, tolerability, and survival, Tycel.
I think the efficacy endpoint is without question. It hit the primary endpoint, and it successfully proved that obviously that given a BTK inhibitor with BR did have at least upfront benefit, at least in a complete response and progression-free survival sort of aspect compared to BR alone. So I don't think there was much debate about that. I think any of the qualms or concerns that came were with the unexpected or unexplained deaths that came in the combination arm, which, caused a bit of pause. I mean, as we sort of take into account, especially as the more and more we've used bendamustine and rituximab in mantle cell lymphoma, I think it's proven to be a quite effective regimen, probably more effective than any of us would have initially assumed in this situation. So the argument has always been because, are we losing patients by not giving them the best sort of combination up front, which this would have been at the time, versus using BR and then, rescuing these patients later. And I think we have numerous studies that do show that we have some attrition of patients from first line, second line to third line. I'll bet, some of the concern is that a lot of the data set that we depend upon haven't really taken into account some of the novel treatments and some of the improvements in supportive care that we have, and probably some of the better diagnostic techniques, because we can probably eliminate some patients that we know that won't respond very well to chemoimmunotherapy up front, and save those patients from that toxicity and then give them other treatments which may provide some more durability.
And we'll get into that more with your cases. Michael, anything else you want to say about SHINE? Do you think there's more BTK toxicity when you add BR, or is it really just the two separately?
So there are two possibilities. One possibility is due to the ibrutinib toxicity leading to more death in the in both arms. In the experimental arm. However, there's also a possibility that this is due to chance. Okay, for example, the SHINE study, at the study entry, the patient's average median age was 71 years old. And the SHINE study has a follow-up of 8 years. So when they are calculating when we are talking about the deaths, we are talking about the deaths of 79 years old. They have developed many comorbidities that may not die from the ibrutinib, but there could be the chance. But we have so many BTK inhibitors. The FDA said, well, you have 50% chance due to the ibrutinib toxicity. Let's withdraw it. I may agree to withdraw ibrutinib as an academician in the older people. I certainly do not agree to withdraw ibrutinib in the younger people, but that's beyond the point, right?
So let's move forward to earlier this summer at the EHA meeting where you presented the ECHO study. Like SHINE with acalabrutinib looks like to me. Michael, what did you, can you talk about the design of the study and what you reported and what you think it means?
The design of the ECHO study, in terms of ECHO really echo the SHINE study because they have basically the similar design. BR with R maintenance with acalabrutinib versus BR with R maintenance versus placebo. The significant difference between the two is that in the SHINE study, crossover from the placebo using ibrutinib was not encouraged, was not supported. So even let's see, the patient is on SHINE study, he lives in Chile, and maybe the placebo group, they progressed. Ibrutinib is not available in that country at that time. So even you want to do the BTK inhibitor, it's not available. But in the ECHO study, that the crossover, if the patient developed the progressed disease in the placebo arm, crossover is permitted, and it was paid by the sponsor. Therefore, 70% of the people had a crossover. So with the 70% crossover, that means the concurrent therapy with BR plus acalabrutinib is better than the sequential therapy with BR first and upon relapse with the acalabrutinib. So you can see 70% crossover do not affect the overall survival at all. So this data strongly support the concurrent upfront therapy instead of sequential therapy.
And I guess it's a little early to talk about survival, but what about
the survival has a significant difference is that there's a clear trend of improvement, although there's no stats difference. However, this is dramatically different from SHINE, where the two curves are on top of each other. Assuming, I'm not assuming that we only have 1/3 of the patient population affected survival. We still have 2/3 who have not met the overall survival endpoint. So the curve could be, continue separate or crossover in the future.
So I'm going to get Tycel's input on this in a second, but just can you comment a little bit on the safety profile of ECHO and maybe compare it indirectly to SHINE?
So the SHINE study, the atrial fibrillation was 16%, 14 to 16%. And the placebo arm was 6%. But look at this population. The atrial fibrillation was 6.1%. In the acalabrutinib group was 4.4. There's no significant difference. Look at the hypertension. It is actually more hypertension in the placebo group, more major bleeding in the placebo group. Infections, of course, slightly little more in the acalabrutinib group. Secondary malignancies was nearly identical, a little bit more in the placebo group. And this tells you that the acalabrutinib is much, much more better tolerated than the ibrutinib in this trial.
Okay, Tycel, what were your thoughts and what are you hearing from your colleagues about this study? Is this a regimen you think has a potential role in mantle cell?
I think this is a regimen that would likely be utilized in a community setting. I think, no tongue in cheek, I echo what Michael mentioned about the safety. I do think that this proves that acalabrutinib has a much better safety profile than ibrutinib, especially in these older patients. So I don't think that is a concern at all that you're getting the extra added toxicity in this patient population. I think we'll wait and see what the long-term overall survival data shows in this patient population. I do think in some of the academic settings, you'll probably get some of the same discourse that happened with Shine, where people will always wonder if you're getting any real benefit by combining these drugs versus giving everything up front. So I think when they give some of the subset analysis, that'll be really helpful, especially in some of the high-risk patient populations, to see if they benefited from this combination, because I think that's the only thing we just don't have from the published data at this point.
So, Tycel, here's another study looking at zanubrutinib and rituximab versus BR, slightly different than the ECHO study, and I guess we'll see where that leads. But I want to just take a step back and just take a deep breath and ask both of you a very straightforward. I asked this question to Michael yesterday. I'm going to start out with you, Tycel. I asked Michael this. We did a program a year ago. I asked Michael the same question, and then I was quoting him for the next 6 months and throwing it out to people to see whether they agreed. And it was an interesting response, I was going to say, because Michael likes to get out there on the cutting edge of treatment. But let me start with you, Tycel. Here's the question I asked Michael yesterday. I'm going to ask him again, which is, in general, right now, if you are going to start somebody on first-line therapy for mantle cell lymphoma, understanding in general that you're going to individualize it, and let's say it's a standard risk situation in a younger and an older patient, and let's put aside reimbursement. Let's assume you can access anything you want to access. Right now, for a younger or older patient, Tycel, what's your feeling in terms of what the optimal first-line therapy is?
I think the optimal frontline therapy is probably the same in these older or younger patients. I think we're all hopefully moving toward an era where they're going to get maybe a fixed duration of some of these oral novel agents, very similar to, Michael's Windows trials, maybe except without the consolidation with chemotherapy for patients with standard risk. I mean, I think we really need to get away from the dichotomy that we have where we have older and younger. And I think optimally, if we had a standard of care that sort of captured the vast majority of patients with mantle cell lymphoma, I think the field would be better for it. So, that being said, with what we have today, I still think BR is a good option for older patients. And if we have younger patients, I think at this point, outside of the context of a clinical trial, I guess we're sort of really the only thing that's really stood out that we can get access to is probably the triangle regimen. And I still say that with a lot of hesitation because I would still like to see more long-term follow-up of that regimen before that's something I fully commit to, because I think the follow-up is still just too short.
Before I get back to Michael, one other question, Tycel. I want Michael to answer this too. When you think about BTK for mantle cell, in your mind, is Acala and Zanu like interchangeable? I mean, I know if whoever gets the data, Michael, do you?
Yeah. So, acalabrutinib can cause a pretty bad headache in some of the cases. And zanubrutinib is more neutropenic, probably more fatigue a little bit. So otherwise, very similar drugs. So a lot of people use interchangeably in the clinic. I do that too sometimes.
So let me ask you again, Michael. Tycel, I'm going to pin him down a little bit more as we go through this, but he kind of gave a general thoughts about how he thinks through therapy, but I want to try to get more specific. And Michael, again, I'm going to ask you the same question. You've got a young patient, who could potentially tolerate, a transplant, et cetera. Right now, I know you have a million trials there at MD Anderson you want to put them on, but if they're not going to go on a trial, and how are you approaching a younger patient? How are you approaching older patients?
In younger patient, I absolutely pro chemo-free therapy. If I also totally against stem cell high dose chemotherapy followed by stem cell transplant. Absolutely not. Okay. Then in older people, when they cannot tolerate such therapy, I would use chemo-free therapy, acalabrutinib, rituximab, zanubrutinib, rituximab. And people see I'm more on the cutting edge. Yes, as my historical rule is progress, pro new things. Okay, so I would definitely interpret the triangle study as a positive, not do stem cell transplant. I would totally use chemo-free therapies, even in older people, and use, by chemo-free combinations, even before the mangrove study reads out. Thank you.
So, and we were talking about the triangle study. Can you comment on that, Tycel, and what your thoughts are? What were you doing before you saw these data? And how did these data affect your approach, particularly to the issue of transplant?
Yeah, I mean, historically, we were probably doing some semblance of RMA. We didn't use DHAP, but we used high dose cytarabine with the stem cell transplant, and then our maintenance. I think shortly before this came out, there was a cooperative group trial where we were enrolling patients that randomized patients to our maintenance versus transplant plus our maintenance based on their MRD assay. But after the triangle trial read out, I do think it gave people quite a bit more pause about using auto transplant consolidation because it's never really shown a survival benefit. And with the data that they had, I mean, even the early data, it strongly supports that there wasn't a lot of benefit in the patient population with an auto transplant. So,
Michael, any thoughts about Triangle and the way it's people have received it and acted on it, and any comments about that?
I think we should welcome the new thing, and high dose chemotherapy is too much toxicity. We should welcome the triangle study, and no study will be ever perfect. Okay, we always wish we could do that. We could do that, but please, our time is new. Our generation is new. Our technology is renewing all the therapies. So we need to welcome the era of the theme of our time.
So I want to get into that more and hear some other data sets that Michael commented on in his talk, particularly related to the issue of chemo-free. Michael, you were saying you think mantle cell is going to become the new myeloma and have a quadruplet or quintuplet therapy moving forward?
I think
What
so.
about acalabrutinib rituximab?
I think I think it's maybe that study we should do, Neil. I like your intuition, because remember, three is better than two, and four is better than three. That's the mathematics, right? But of course, you have to work out the details. You have to see maybe higher risk patient need four agents instead of three.
Can you talk a little bit about your?
Yeah.
Can you talk a little bit about the bovine study?
Bovine study is a study led by Dr. Kumar and from Memorial Sloan Kettering Center, and together with a partner, I think Dana-Farber in Mass General in Boston. So they only enrolled p53 mutated patients with mantle cell lymphoma in the front line. So they enrolled 25 patients, and here, we have never seen a study just aimed for the p53, right? So they actually have a very good result. Next slide, if you can. The response rate, even in the p3 mutated patients, is very high, with over 90%. Yeah. So first of all, I really love the idea of doing a trial with a triple combination on p53, but I have my concerns. Number one, the maintenance therapy was not very long in this. I would give an extra 12 months. Number two is that the number is still very small, and so I'm
Tycel, any thought? Any thoughts, Tycel? I mean, I keep seeing, BTK, anti-CD20, venetoclax in different forms.
No, I think obviously the push of the field is to try to get BTK inhibitors into more patients than less. But I think I agree with Michael in the sense that Bovin was a very ambitious study. It's very hard to run a study with just P53 mutated patients because there are not that many, and mantle cell is a rare disease overall. But I think it's encouraging. It was only 20 patients, but hopefully with the larger data set, because I think their plan is to enroll 50, we'll get a clearer picture of how these patients pan out. I do think it supports that, these novel treatments help somewhat overcome some of the poor risks that we see with P53 mutation and with straight chemotherapy. I mean, I know you're not supposed to do cross-trial comparison, but if you look at the P53 high expression patients from Triangle and compare it to what we get with Bovin, the two curves look very similar. Albeit again, a little bit different how at least the first 20 patients with Bovin were from molecular testing, and the Triangle study used IHC, so it's about a 20% chance that they misclassified some patients in the Triangle trial.
So a couple people in the chat room, Michael, want to know what your thoughts are about your echo data. It sounds like you're more inclined to just give a rituximab or obinutuzumab without the bendamustine, but you tell us.
So I do think if in the frontline place, not all the agents are available to other people. So if your community use bendamustine rituximab, please add acalabrutinib if the drug is available. It is much better in terms of PFS. It is a very clear improvement in the overall survival signal. And so if you have to use BR, please add acalabrutinib, especially for the high-risk patients. But if you are able to afford chemo-free therapy, we'll welcome the future, use chemo-free therapy.
So let's get into some cases and maybe also looking back at cases of people who've been treated before and think about how you would treat them today. I mean, things are changing. I heard that last year from Michael, and now we're seeing more and more data moving away from chemotherapy. But let's bring it into cases. This is a higher risk situation. Younger patient, 60-year-old woman, Tycel. How did she present? And what was your take on her presentation? Did you consider her a high-risk situation?
Well, she had a very sudden presentation of disease, and I'll be honest, at the time that she presented, I mean, I think we knew, pleomorphic variant was bad. A lot of the data sets that have come out that really support these elevated Ki-67s were not necessarily really forthcoming. So we didn't really classify her as I would today as a high risk patient per se, other than she was a very symptomatic patient with mantle cell lymphoma who was young enough to fit into that we would consider to be eligible for a stem cell transplant. And, as was the standard at the University of Michigan at that time, we basically gave a high dose chemo and a stem cell transplant. So our preference was a Nordic regimen, and she was taken to a transplant. We did use our maintenance, but unfortunately the patient had a very short relapse and was subsequently started on a BTK inhibitor. And as we discussed before, again, had a very short duration of response to the BTK inhibitor.
So, Michael, any thoughts about this case? And what are your thoughts about managing a patient like this today?
Okay, so if I have to face the patient today, it is clearly now the risk factors for mantle cell lymphoma are much better and clearly defined.
Mm-hmm.
If the patient has there's many factors, but the three most important ones are the P53 mutation, plus total pleomorphic morphology, and Ki-67, 50 higher or less. So this patient have two of the three most classical high-risk factors in mantle cell lymphoma. She, on day one, has a very aggressive disease. And that's why the patient did not, with a high-dose chemotherapy stem cell transplant rescue, and the patient relapsed very quickly within probably around 6 months or so. Mm-hmm. So I would definitely use the triple combination, the best we have, maybe for quadruple function in the future when we have the data, I would use a BTK inhibitor, a BCL2 inhibitor, plus a anti-CD22 CD20 antibody, and really upon relapse, I would immediately go to CAR T-cell therapy with a brexacabartine autoleucel.
You alluded to something in addition to a CALR or BTK, anti-CD20, and venetoclax. Would that be chemo?
No chemo. I would. I may have prolonged the triple drug maintenance for if long patient does not relapse. I'll keep them on triple resistance. This is very, very important, the maintenance in this kind of high-risk patients.
So second opinion, Tycel, this patient comes to you for a second opinion. They saw Dr. Wang and said, oh, Dr. Wang says I should take a Calo-Ven and rituximab. I don't know, was it a Ben or a rituximab?
Rituximab, venetoclax, rituximab.
Okay. So second opinion, Tycel, you can say that's a great idea or maybe something else.
Yeah, I mean, I think as far as the standard of care option, I think that's a good idea. I would never give a patient like this chemo today. So, unfortunately, you live and you learn.
No.
All right. Well,
at that time, the data was not available at Tycel. It was several years ago.
No.
Yeah.
I mean, it wasn't that long ago, too, and things are changing fast, at least in the last few years from what I've seen. So Tycel also has an older patient, and, whether or not this older, younger thing is going to, continue with mantle cell, we'll see. But in any event, he had a patient who had a mantle cell who was 80 years old. So I want to hear both about this case, because I guess he ended up doing well on BR. He got a 5-year response out of it, but then went on ibrutinib and had a bunch of problems, mainly cardiac. So let's talk about what happened to this case, Tycel, but also, again, after we get through talking about this case, how you might approach a patient like this today. But maybe you can kind of present to Michael what happened with this man.
Yeah, 80-year-old, good state of health, found a lymph node in his right axilla. I mean, as we are common to expect, he went back and forth with his PCP, antibiotics. Eventually, had an ultrasound biopsy showed mantle cell lymphoma. Patient was symptomatic by the time I saw him with night sweats. The patient was treated with bendamustine, 90 milligrams per meter squared, and actually tolerated the treatment quite well. Obtained a complete response and was in remission. At that time, we did not necessarily know or have any supportive data about our maintenance, because the only randomized trial we had was negative, so they did not get maintenance. So remission 5 years. At relapse, the patient was started on ibrutinib, which was the BTK inhibitor, most appropriate at that time. Patient had a resolution of his, recurrent right axillary adenopathy, but had a new onset leukocytosis, which we expect with margination from the BTK inhibitor. Patient tolerated the treatment well for a short period of time and had, again, a clinical response, but then unfortunately had AFib with RVR. Was discharged home after reverting to sinus rhythm, but not started on anticoagulation because of concern with bleeding with the concurrent use of ibrutinib. Still had more issues with AFib, and so the patient was planned to be started on amiodarone, and oddly enough, there was an article in a cardiac journal which mentioned the bad interaction between amiodarone and BTK inhibitors. So we had to discontinue the ibrutinib at this point because obviously it just wasn't tolerable, and the patient was started on R squared with some dose reduction of lenalidomide.
So, Michael, any thoughts about this case? And also, maybe you can comment a little bit on how you approach patients who have a history of atrial fibrillation before they ever got mantle cell.
So first of all, if this is several years ago, so if I treated a patient today, in an 80-year-old man, I would use chemotherapy therapy without bendamustine. My preference may be a acalabrutinib rituximab, but knowing ibrutinib is associated with such a high atrial fibrillation rate. So upon the development of AFib, I live in the luxury of Texas Heart Institute, right in the medical center of Houston. So we have a very strong EP program. I send the patient to them. They always do a nodal ablation. So nodal ablation does not get rid of the fibrillation of the atrium. You still need to anticoagulate them, but you don't need amiodarone. So in order to totally avoid anticoagulation, you have to do another procedure called the Watchman procedure to get rid of get the auriculum, get rid of the wall flow. So for this patient, I would totally see if we can do a nodal ablation to get rid of usage of amiodarone and continue acalabrutinib. But if the rhythm is still there, if the rhythm is still good, I totally agree with the Tycel. This patient on the lenalidomide rituximab therapy. I think that's what the patient need. Thank you.
So let's move on and talk a little bit about relapse disease. I'm really curious where you all see this. Obviously you just saw with this last patient what has been the model, which is given chemotherapy, anti-CD20, and then BTK on relapse. Whether or not that's going to change with more BTK up front, that's going to change second-line therapy, we'll see. But either way, Tycel, you would expect pirtobrutinib is going to continue to have a critical role, not only in relapse disease, but I think trials looking at in the upfront setting. Can you comment a little bit on what your understanding is about this agent, and particularly as it relates to mantle cell in terms of efficacy, tolerability, and how it's different from the covalent drugs?
Yeah, I think the easiest thing to answer is the last part. It's different in obviously the covalent drugs are permanent binders, to the cysteine 481 site on the BTK receptor. So once they bind, they don't let go. And obviously in certain diseases like CLL, that leads to binding site mutations. I think unfortunately we haven't seen that as sort of an easy sort of answer to why we have BTK resistance in mantle cell lymphoma. It seems to be a lot more complex mechanism that I think we still struggle to really completely answer that question. But I think the study by Michael was very monumental, because again, before this trial, the only thing that we really had that showed any efficacy in it, like a post BTK space, was chimeric antigen receptor therapy with Brexacel, which you can't just walk to any sort of oncology office and get a CAR T product. And so at least pirtobrutinib in this sense was something that you can go and get as an off-the-shelf sort of product to help stem the tide, because obviously, as you can see when the waterfall plot, a very high overall response rate in patients who are relapsed or refractory to a covalent BTK inhibitor. But I think the bigger point from this is the safety of pirtobrutinib was quite impressive, and how it seemed that this was even a further step from the second generation covalent drugs to another drug that appeared to be quite safe in this patient population. So I think moving forward, I do think it's a good option. Obviously in certain patients, depending on when they relapse, it may not be necessarily a very durable option, but it will give us time to get patients to hopefully another more effective therapy such as CAR T.
And that does bring up that question, Michael, and I'm curious, in patients who are eligible for CAR T, in general, do you send them right for CAR T? Do you use pirtobrutinib as a bridge? And any more comments about tolerability with pirtobrutinib? Do you see it having a future in first-line therapy?
Absolutely. When you use pirtobrutinib after covalent BTK inhibitor, the response rate is around 51%. But if you use pirtobrutinib without a prior exposure to any BTK inhibitors, the response rate is 85%. So I think that pirtobrutinib should be used in many cases before the covalent BTK inhibitors, and we have 2 clinical trials at the front line. So this is very important. But as the bridging therapy, whenever we want to get to the CAR T therapy, usually the mantle cell lymphoma is pretty refractory already. Mm-hmm. Single agent pirtobrutinib as the bridging therapy is inadequate with only a 50% response. We need a pirtobrutinib in combination with at least rituximab, and the most powerful combination I use is a Cytoxan, dexamethasone, rituximab with the concurrent radiation to dramatically reduce the tumor load pre-CAR T. That has worked out very much in our favor.
What are the design of these first line trials? Were these phase 3 studies with
Uh,
pirtobrutinib up front?
yeah, these are single center investigator initiated trials.
Right. So, what about CAR T, Tycel? How does that fit into your approach? What do we know about bispecifics? And how do you think about these things in the older patients, the typical mantle cell patient?
Yeah, I mean, as we know right now, the two the two approved standard of care options that seem to be most effective in the post BTK space would be, I mean, Brexacil, and then the data with Lysocil. I think for the recent update, it does appear that Brexacil may be a little bit more effective than Lysocil, especially in the BTK refractory patient population. But both drugs, obviously one-time treatments. Both drugs obviously use the patient's T cells to try to fight off the cancer. So I do think, obviously, with the AE profile of Brexacil, there is always some concern, especially with older patients. I would say mainly because of the cytokine release syndrome risk and the neurological toxicity. That seems to be not as much of a concern with Lysocil, but as I mentioned uh, at the recent ASCO update, Lysocil from that subset analysis did not appear to be as effective in Brexacil in that patient population. The bispecific antibodies present another option, but whether it's glofitamab or Mosin-Pola, I think we still need more follow-up and probably bigger data sets because, again, the numbers per se probably aren't comparable to what we have with the CAR T agents. And so until that sort of feeds out, I mean, again, these are good hypothetical options, but we just can't necessarily get our hands on them in every patient outside of compassionate use at this point.
You mentioned Mosun Pola, which kind of surprised me. Where did the Pola come from?
Maybe Michael can answer that a bit better.
Michael.
So yeah, we we Paula has some activities in the earlier phase trials, not studied specifically for mantle cell lymphoma. So they first did the Mosun Pola in large cell lymphoma. They saw great result. That's why they enrolled on the mantle cell cohort. So that's why we locked out. We actually have a very good efficacy. However, like Tycel pointed out, it's only about 20 patients, so we need more cases.
So, Tycel, right now, what's your criteria to allow have a patient go for CAR T? If you have a patient who's borderline, would you use Lysocell?
Uh, I can't say we've actually used a lot of Lysocell. I think for most of the patients, we've actually used Brexacil as our CAR T of choice if we had to use standard of care, and just have a very upfront discussion about the risks that come with the neurological toxicity. Um, just because of, again, as I mentioned, I do have some hesitation if a patient has progressed on a BTK inhibitor. Now, if they were BTK naive, which is rare, then I think Lysocell would be a very good option because the safety profile is quite a bit different than what we see with Brexacil in this patient population.
So, Michael, we're getting a lot of questions in the chat room about venetoclax. People are thinking about their experience with CLL. Do you need to look out for tumor lysis syndrome? Can you talk about the Simpatico study that looked at ibrutinib plus venetoclax and comment in general where you bring in venetoclax and mantle cell and how you do it?
So the mantle cell lymphoma, different from CLL, is that CLL always presented with the lymphocytosis,
Mm.
but the mantle cell lymphoma only about a 10% lymphocytosis. So this is a very different. So usually you delay you first debulk with the agent for 2 to 4 cycles before you add venetoclax. But in the simpatico, there was a smaller lead-in trial where we tried the adding venetoclax in the second cycle. It was safe. That's why we used the same design in the randomized portion. So the earlier use of venetoclax in the sympatico trial was based in the lead-in phase where it was deemed to be safe. So I really think that for mantle cell lymphoma, you don't need, especially in the relapse setting, you don't need a much too much lead-in. You can almost start it concurrently with in the first cycle.
So actually, you have an interesting case, Tycel, in the chat room from Dillip. This is a topic I was going to actually ask you about in the beginning. I forgot to bring it up, and I think we're going to get into it right now. Yeah, I'm going to read this to you. I had a man in his late 30s with enlarged tonsils, put off removal because of work for several months. When we removed one, it was positive for mantle cell, confirmed at Dr. Wang's place. He went to MD Anderson, and they recommended chemo. This is in the pre-BTK era, and he declined it. And he's been off treatment now for a long time. It doesn't say exactly how long, but he's doing fine. And it was considered a low-grade tumor. So, Tycel, can you comment on the issue of indolent mantle cell? And I don't know, maybe, Dillip, you can tell us how long you've been following this patient without treatment. What's the clinical presentation? What's your criteria to hold treatment, Tycel?
Yeah. So the textbook definition of an indolent mantle cell lymphoma is one that normally presents like a CLL patient, so non-nominal leukemic patient. So I think that's the textbook definition. I would say in general, I think I try to use a more objective sort of situation of if a patient is asymptomatic without a blast or pleomorphic variant of mantle cell lymphoma, I tend to lean toward observations from these patients. I think we have at least several retrospective studies now, one from Cornell, one that was a collaborative group that was published by Jonathan Cohen, and a recent data set that came out of the British that suggests that, I mean, for the most of these patients with mantle cell lymphoma, if they are asymptomatic at diagnosis, irrespective of whether they have nodal disease or not, that you can monitor most of these patients without any long-term detriment to the long-term survival and outcome. So at this patient, I think if they just had tonsillar irritation, and if it was resolved with the surgery, I agree, observation is a good option. And even if they were still having issues in the tonsil, maybe localized radiation and further observation of the other areas if the patient was not symptomatic.
Second opinion, Michael? He apparently went to MD Anderson, this patient, at some point.
So pre-BTK era, we have 20 other physicians treating mantle cell lymphoma. I don't recall that my patient, this is my patient. But anyways, most of the lymphoma, mantle cell lymphoma invading the tonsil are all 2/3 of them are very aggressive. And you got to give them either radiation consolidation or you need some kind of a systemic therapy because they can go to the cranial nerves, they can go to the brain, they can be go to the orbital mass, and they can be very aggressive. So this patient is the exception because he had indolent lymphoma, and he was observed for a long time without the relapse. So this is belong to the indolent case. Watching the weight is appropriate.
So actually, Dillip in the chat room says he followed this patient for 5 years and then he moved, but the patient was doing great when he moved after 5 years. So really interesting
So it was my patient.
Case.
Good.
Yeah.
The patient is still alive.
Right.
I'm very happy. Yeah.
So we had Tycel presenting some cases to Michael. And actually, Michael, in the thing we did yesterday, presented like 8 cases, but I picked out a few of them just to throw out to Tycel, see what he thought. So I love this first one. 60-year-old man. What happened with him, Michael? You can present it to Tycel, ask him what he would do.
Okay, 60-year-old man with newly diagnosed mantle cell lymphoma CLL type, positive cyclin D1, negative SOX11 bone marrow is infiltrated by MCL 60%. His spleen is 25 centimeters, and his peripheral white cell count is 100,000. So A, start acalabrutinib, B, start rituximab in the outpatient clinic, followed by adding acalabrutinib. C, admit the patient to the hospital, start rituximab at 25 ml flat rate without escalation, and add acalabrutinib after 4 doses of rituximab. D, start zanubrutinib, and E, start pirtobrutinib.
So there you go, Tycel. This is like the boards.
Sure.
Go for it, Tycel.
I mean, I guess in this situation, assuming this patient was having symptoms, I would actually either do A or D because I think it would be very hard to get rituximab into this patient right away with a white count that high because, as Michael mentioned, mantle cell is quite sensitive to CD20 therapy. So Normally, to avoid some infusion reaction, I would have started acalabrutinib or zanubrutinib, and I would likely just probably add the rituximab later once we got some decrease in the white blood cell count, then continue that
So,
doublet for at least 6 to 12 months.
so Michael, what did you do?
So I was afraid that you started a BTK inhibitor, the lymphocytosis could even worse. So I was very careful. I put the patient in the clinic, in the hospital, first him for a few times, and then when the WBC came down below 50,000, we started very carefully, Tycel was concerned about, with the rituximab at 25 ml per hour without escalation. So the patient did pretty good, and after 4 doses of rituximab, I added, I think at that time was acalabrutinib.
So that's a great case. So Michael, question from the chat room. Seems like a pretty typical kind of scenario. I'm sure you see this all the time. A patient who relapses after getting first-line BR. And I guess the question here is, obviously BTK would be a consideration, but what about adding venetoclax in a patient like that?
So if the patient have performance is good, and it can tolerate two drugs in the symptomatic study improved greatly improved failure progression-free survival, and it also have a higher CR rate, and also have a overall survival trend. If the patient tolerant is well, I would use the two-drug combination. But if the patient is frail and cannot tolerate two drugs, maybe one drug with or without rituximab would be also good.
And I guess from what you were saying before, how do you decide which BTK? I'll go put that to Tycel.
Okay.
That really depends on whether I want a Coke or a Pepsi that day. So
Okay.
I look at the two of them as very interchangeable.
All right, so here's another one for you, Tycel. This is maybe a little bit more straightforward, but I'm curious anyhow. Michael, you want to talk about? Go ahead.
A 70-year-old man with a history of mantle cell lymphoma that relapsed after chemotherapy, who was started on acalabrutinib. During the first week of therapy, he developed a mild headache, scoring 2 to 3 out of 10. A, treat headache with ibuprofen. B, stop acalabrutinib and treat with aspirin. C, switch acalabrutinib to zanubrutinib. D, hold acalabrutinib until headache is resolved and then restart at a reduced dose. And D, hold acalabrutinib until headache is gone and then restart at the same dose.
You forgot F. Drink Cuban coffee.
Yeah.
Yes, I take F.
Okay, good. See.
Well, actually, we've been asking this for so long, and it's still amazing to me that people still have not heard about caffeine. I don't even know if it's actually even true, but I hear it a lot. But really, but actually, for all the times that we talk about it, Michael's answer was very interesting to me. Michael, I thought he was going to say take caffeine. That's not his answer. Tell me your answer, Michael.
Yeah. So the headache for the majority of the times caused by acalabrutinib is it's transient, it's self-limited. It's like you last about 2 to 5 days, and so you want to use ibuprofen, Tylenol, it's all okay. But I use Furoset. Furoset have caffeine in it. It's very effective, and you can also drink coffee, no problem. But the key is that the headache, you should not reduce the dose. Even if you stop the pill, the headache usually goes away, and then you can restart them when the headache is gone. And after a few cycles, the headache will go away automatically. So my choice was E.
I thought that was pretty interesting. All right, one more from Michael for you, Tycel, 71-year-old man. This really kind of gets into strategy
the history
for managing
of
relapse disease.
Presented for continuation of therapies for relapsed mantle cell lymphoma. He was previously treated with the rituximab, lenalidomide, R2 therapy, bendamustine, and rituximab ibrutinib. However, he further relapsed with a tumor of 3 centimeter near the mediastinum and other enlarged lymphadenopathies throughout the body. Ki-67 is only 10 and morphology is nodular. What are here are the potential therapies, including acalabrutinib, induction chemotherapy followed by stem cell transplant autologously, chemotherapy with the hyper-CVAD, portobrutinib, and arrange for CAR T-cell therapy.
So Tycel, what strikes your fancy here?
Yeah, I wholeheartedly think that no mantle cell lymphoma patient should die without ever seeing a BTK inhibitor. I mean, so in this situation, I would start a BTK inhibitor.
Well, he got ibrutinib. He got ibrutinib already.
I don't see ibrutinib.
Right?
Oh, sorry, I didn't see that. So in this patient, pirtobrutinib and then bridge as a use, but I would try to get the patient the CAR T.
Bingo. Ibrutinib, if used, as a bridge, the Ki-67 only 10%, that they should be very sensitive to pirtobrutinib. And so if the patient is in remission, you can watch a little bit. If not, the patient, you don't have good result, start a CAR T. I agree with Dr. Phillips.
So let me see if I can just squeeze in a couple more questions from the chat room here. KY, interesting question. Is there a role for MRD in mantle cell Tycel?
I think we all think that MRD is a very helpful analysis. I think the problem is that it's very difficult to get in a standard of care setting. But the majority of the trials, a lot of them are based out of Germany and have shown that an MRD undetectable patient has a longer progression-free survival than those who are MRD detectable, even if their PET scan or CT scan shows that they're in remission. So that's a yes, and we hope that we'll be able to integrate it more so in clinical practice if one of these assays gets an FDA approval.
So one final question back to you, Michael. This is from Hassan. Interesting case. I don't know whether he made it up or it's real, but anyhow, here it is. Either way, it's interesting. 65-year-old man with lymphadenopathy and lymphocytosis, 15,000. FISH shows 1114 translocation in 25% of cells. 13Q minus in 50% of cells. Flow consistent with CLL. Would you treat as CLL or MCL? Or maybe it doesn't matter whether it's CLL or MCL. I don't know anymore.
I would treat it as MCL because MCL have worse prognosis, and they share the same drugs anyway, right? I would treat it with a chemotherapy therapy with a triple combination. Of course, you have to use the rituximab to reduce the counts before you add the other drugs. Thank you.
So Tycel and Michael, thank you so much for working with us today. Audience, thank you for attending. Be safe, stay well, and have a great night. Thanks so much, Tycel.
Thanks,
Michael.
Bye-bye.
Thank you.
Bye-bye.